Hello, good afternoon. I think we're going to get started. On behalf of Cape Cod Healthcare and Emerald Physicians, I would like to welcome you all to our Wellness Trails event. My name is Kumara Siddhartha. I am a physician, a medical director at Emerald Physicians, which is part of Cape Cod Healthcare. And I'm thrilled to be here sharing this Wellness Trails with you, which is a health education series that we do pretty much monthly for the whole year. We're going to take a break during summer. And the idea here is to educate and empower you on topics that matters to you. So we chose this year's topics and themes based on the input that you gave to us during the past few months when we send out the survey, the online survey, after every one of these events. We had the opportunity to get the feedback from you, look through it, and choose these topics to deliver something that you wanted. So this particular one, which is based on your feedback, is going to focus on joint health, spine health, and how to make sure that we can continue to have less pain in joints and be able to be mobile and ambulant and do the things you want to do. So we have a fantastic lineup of speakers, some of the best of the best in their subject matters, who are here to speak today. And there are a few housekeeping notes. The restrooms are out behind this door to the right side when you go out of this door. There are some snacks, some smoothie samples in the back end of these tables, and there is water also in the back end. And for questions, I would ask you to keep the questions until the end of the speaker's speech. So once they finish their talk, you may want to ask the questions not in the middle. And we have lined up a lot of lectures for today, so I'm gonna have you to, we may have to limit the number of questions at the end of the session. And there are a few individuals who helped us make this possible. First of all, Julie Bado, could you please stand up, please? Julie Bado is our coordinator for these events. Please give her a big round of applause. This event we started in a small way a year ago, and this has grown exponentially. And Julie Bado, she's like a one-woman show. She keeps it happening, and there's a lot of behind-the-scenes logistics that need to go to make this happen. So, and we also have volunteers now who are helping Julie to make this happen. So, for this event, Elaine and Pat helped out. Thank you, Elaine and Pat. If you're here, could you put out your hand? Elaine, Pat, thank you so much. And last event was helped out by Len and Cindy. So thank you, Len and Cindy, wherever you are. And today's Access AV team, thank you for your support. And the accommodation by Seacrest, thank you so much. And we have nurses Melissa, Sam, Rebecca, and Eilish from Emerald Physicians who are helping us out, checking your blood pressures and at the registration. So thank you. We'll be sending out a survey again at the end of this event. So if you registered in the email that you used, you will get a survey, and we would like to see what you have to say about this event, how we can make this better in the future, what other topics you want to see presented in the future. So we really pay attention to your feedback and take that into account when we are designing this for the future. So thank you for that. And our next event is scheduled for Sunday, June 10th at the Resort and Conference Center in Hyannis. And we'll be exploring behavioral health topics, including anxiety, depression, stress reduction, insomnia, and sleep issues. And we'll look at some stress reduction modalities as well. So we'll move on to today's events. To kick off the speeches, we have Dr. Robert Wilsterman, um, owning and operating the orthopedic specialists in Falmouth for more than 20 years. Dr. Wilsterman is the area's senior orthopedic surgeon, specializing in total joints, arthroscopy, and sports medicine. Dr. Wilsterman is the only orthopedic surgeon at Falmouth Hospital who performs the rapid recovery, minimally invasive technique of hip replacement, called the direct anterior approach. He also does more arthroscopic knee surgery than any other orthopedic surgeons in the area. Dr. Wilsterman graduated from Harvard University, received his medical training at Georgetown University, and completed his residency at the Naval Hospital in Portsmouth, New Hampshire. He was also a medical officer at the USS Shreveport. Dr. Wilsterman is board certified by the American Board of Orthopedic Surgery. And today, Dr. Wilsterman will discuss surgical procedures to gain mobility and decrease pain in shoulders, knees, and hips. Without further ado, Dr. Wilsterman, thank you for being here.
Hi, everybody. It's good to be back. Last year, we talked a lot about how to keep your joints healthy. And I know that everything I told you guys to do, you all did. And so, but maybe there are some people that aren't here that didn't get the message. So today we're going to talk about what happens when it's too late to prevent arthritis. So, like Dr. Sid said, I've been here for a bunch of years. I've raised my family here. I like it here. This is a great place. I'm sure you guys all feel the same, or you wouldn't be here too. Anyway, so when all else fails, surgery is oftentimes the option. When you're dealing with surgery of joints, you're either dealing with a joint sparing kind of surgery or you're dealing with a replacement kind of surgery. If you're going to spare the joint, what you're really talking about is a limited approach, and it almost always devolves into arthroscopy. The thing about arthroscopy is it has absolutely no legitimate role in the treatment of arthritis because it just doesn't work. There's nothing you can do in the joint when the joint is already wrecked. So arthroscopy isn't really what we're going to talk about today. We're going to talk about joint replacement, which is what we're talking about. We're talking about end-stage arthritis. So today we're going to look at the hip, the knee, and the shoulder. So the three most common diarthrodial joints that get replaced. There's other joints that get replaced, ankles and elbows and wrists. Those procedures are more uncommon or less common, and they're not as successful. They're still kind of working the kinks out of all that stuff. So we're not going to deal with that. Somebody said that joint arthroplasty is one of the most cost-effective and clinically successful medical procedures ever advised, and Paul would argue with me about that, but I think it's probably true. It's pretty amazing stuff. And when you think about your grandparents, and for a lot of you guys, your parents, suffering through life at the end of the life of their joints, we live in a pretty amazing time. Anyway, so the history of the thing kind of goes from about the 40s. A guy named Austin Moore invented the monopolar hip, which was the world's greatest thing. It lasted until this year when the people that make it quit making it because they weren't making enough money off of them. And it's unfortunate because it was a great thing, and a couple of us used them. We didn't use a lot of them, but they're still very useful, but they're no more. The total hip came around in 60, the knee in the 60s, the shoulder sort of a little bit later. And then the last big thing was this thing called a reverse shoulder that we'll get into when we talk about the shoulder. So when you think about joint replacement, a lot of people think that you're changing a part. Like, I put a new generator in my Ford Falcon. It's not really like that. I had a lady the other day ask me if I would give her her old knee because she wanted to put it on the mantelpiece. And it was, aside from the fact that that was really weird, it was, it just doesn't work that way. I mean, you don't get an old knee. You don't get a part. You just resurfacing is what we're doing. We're not really, we're not replacing. We're resurfacing the joint as it exists. So, and it's basically a ball on a stick in your shoulder or your hip, or it's a metal skid on a metal platform in the knee, and it has to have something in between the pieces of metal. So the thing that fits in between the pieces of metal is plastic, almost universally. And in the old days, the plastic was crappy, and that's how come the things wore out. And then in 1998, somebody invented this stuff called cross-linked polyethylene. It's very hard, it's very tough, it doesn't wear out as much. It doesn't lead to this thing called osteolysis, and a whole new era was kind of born. They dialed it into the knee about 10 years later. It took a while to get it in the knee because it was too hard and it kept cracking. So the old days and the new days. In the old days, everybody stayed for 3 days, at least. You stayed in the hospital for 3 days, then you went to a skilled nursing facility, which is code for a nursing home. And you ate marginal food and slept in a marginal bed, and you got treated really well because the people that work there are wonderful. But now we don't want people to have to do that. We want people to go home. 2 days is a lot of time now for a joint replacement person to be in the hospital. 1 day is oftentimes possible, and almost everywhere else in the country, same-day surgery centers are doing hip and knee replacements at a furious rate. It hasn't caught up to New England for some reason, but it's everywhere else it's happening. And we're talking about big numbers. 700,000 knees a year now. They're looking at 3.5 million a year. This is just in the States by 2030. So, I mean, it's kind of crazy. So to understand the knee, you have to understand the anatomy. So the anatomy of the knee, basically is all about articular cartilage. Just you're going to hear articular cartilage a whole lot in the next 20 minutes. That's the stuff that gets sick when your knee or your hip or your shoulder or any other joint wears out. Articular cartilage is the chewy, white, rubbery stuff on the handle end of a drumstick. So if you think about all of your bones inside a joint are covered with that stuff, and it's pretty thick. And so it takes a while to wear out, but the stuff doesn't know how to heal itself, so it does wear out. This drawing here shows that the meniscus is a solid blue thing, which is a crazy cartoon since they're not solid and blue. They're shaped like a C. They were called semi-lunar cartilages in the old days because they look like a crescent moon. So ignore that part of the drawing there. And so it's for, so femur is the shin or the thigh bone, the tibia is your shin bone, and a patella is your kneecap. So that's what you're looking at. And these things are on the sides are really important. The collateral ligaments. This is why it's not like swapping a car part. You have to work inside the human constraints of the joint, because if you destroy the whole joint to replace it, it won't work. So you have to leave a lot of stuff behind, and that's one of the important concepts of joint replacement. So survivability. How long is my knee going to last? There are studies out there that are showing 96% survivability at 20 years, and that's with old plastic. So I don't know, 30 years doesn't seem too unreasonable. Now, lots of you guys know people, or lots of you guys have had joint replacements that didn't last that long. They don't all last that long, but they can last that long. And basically, the picture on the right is just sort of the basic deal. The femoral component is a metal thing. The plastic spacer, go figure, is plastic. And the shin bone piece is metal as well. Whoops. What can you expect? Most people should be able to go back to almost everything they used to do. You shouldn't run, you shouldn't jump. And the one thing nobody can do with a fake knee is kneel on it. Everybody hates it, it hurts, it feels crummy, and they all will tell you that you can't kneel. Doesn't hurt the fake knee, but it doesn't feel good. And time frame wise, 4 or 6 weeks should be the kind of time where you're starting to live a real life again. Some people, it's as few as a week or two. Some people it takes longer, but on the average, 4 to 6 weeks is a reasonable time. And so, we resurface all 3 of the bony components. And just by way of making you more confused, there's different kinds of knees. If you trained with a guy who trained in Boston, you use a thing called a cruciate retaining knee, which means the one on the right, it requires you to preserve this one thing in the back of your knee called the posterior cruciate ligament. If you trained with anybody else, you use a posterior stabilized knee. Does it matter? I don't know. I've had a lot of patients where they have one in one leg and one in the other. They don't know the difference. I don't think it matters. It just depends on where you were trained. So moving on to the hip, like I said, 1940 was sort of the beginning of the hip. The anatomy of the hip is a lot different than the anatomy of the knee. The joint is much more constrained. It's essentially a ball in a socket. And it's a ball in a pretty deep socket. Your hip it moves a lot, but it's in there. And that dictates a lot of the way we treat the thing. But that's the basic anatomy. And just like in the knee, the head is covered with articular cartilage, the socket is covered with articular cartilage. So when it gets buggered up, it hurts and it doesn't move so well, and it gets replaced. The survivability of the hip has always been better than the knee and continues to be better than the knee, and there are people all over the place with hips that are older than 30 years, and with modern plastic, they can last for a really good long time. And you should be able to return to pretty darn normal function. And people ski and people play tennis and people ride bikes and they swim and they climb mountains and they do stuff. You're not supposed to run. You're not supposed to jump. People do. I put a hip in a guy the other day who told me that he was going to run the Boston Marathon. Thanks for the new hip. And I cried a little bit. And he, I don't know. He's either afraid to tell me or he hasn't told me yet. But I guess he did. Some of the expectations are based on the approach. And the approach with a hip is much different than the approach with a knee. With a knee, you make a big incision in the front of the knee and you put in the knee. There's no other way to do it. With a hip, there's a big difference. So basically, this is what a hip gizmo looks like. It's a metal stick with a ball on the end of it in a socket. The ball used to always be metal. Now the balls could either be metal or ceramic. Ceramic balls cost more, but for your more money, you get a smoother ball that doesn't create any kind of corrosion on the stem, because the balls are made out of a different metal than the stem, and it causes a chemical reaction and can create some havoc. So ceramic balls I think are better. Most people agree they're better, but they do cost a lot. They cost less more. That's not even hardly English. The difference between metal and ceramic is coming down as more of the ceramic ones are implanted, and the economies of scale and so on. But that's the deal. So the bearing couple is the concept of what's in between the two pieces of metal. The bearing couple has traditionally been metal on polyethylene. For a while there, we went to metal on metal hips. If anybody has trouble sleeping and they watch TV at night, that everybody wants to sue everybody for metal on metal hip problem. they were a giant disaster. And ceramic on ceramic hips were almost as disastrous. So hard on hard bearings are out, and hard on polyethylene is back. And in the United States, if you do otherwise, you're probably looking for a way to give away your license. So, approach-wise, you can do a hip from the front, you can do a hip from the back, you can do a hip from the side. It doesn't matter. That's a lie. It matters a lot, but everybody's going to do okay in the end. But you're not going to do okay the same way. But at the end of the day, in competent hands, any approach to the hip is okay. They all work well. They just have their pluses and minuses. The posterior approach is easy. We all learned how to do it when we were growing up. You can do it with one assistant who can be completely unskilled. All they have to do is know how to wash their hands and hold a stick. And if they can do that, then you can do it. On the cons, and it also you get a great view from a posterior approach. On the con side, it's hard the people are lying on their side, so it's hard to tell how long their legs are compared to the other one. It's relatively hard to get x-rays, although with digital x-ray it's a lot easier than it was when you had to wait for somebody to run down the hallway and print the picture and run it back. There's a significantly higher dislocation rate, although that's controversial, and that's dislocation rate post-op. So, you're minding your own business and doink, your hip pops out. That's not a happy situation, and we want that to happen as infrequently as possible. And the recovery is slower. It's not slow, because it's sort of standard, but it's not fast, which some of the other stuff is. The lateral approach is the same way. It's easy. I never learned how to do it, so for me it would be impossible, but people tell me it's easy. You can do it with one assistant and you can see well. But there's this thing called heterotopic ossification, which is a deal where blood clot turns into bone, and it happens a lot in this approach for some crazy reason. I was researching this talk, and there were studies that reported 60% of people with HO from that approach. It's not always a terrible thing, but it's not normal. So then the anterior approach, which unabashedly my favorite approach, the recovery is faster. You get great visualization of the socket. I kind of left out the fact that you can't really see the femur very well at all. It's really easy to assess leg length because you walk around to the foot of the bed and you look at the people's feet. We do this with you lying on your back, so you're not on your side, and you can just tell. The dislocation rate is lower. The ability to get x-rays is great because you can use a portable fluoro machine while you're doing the procedure, and you can measure where you're putting stuff as you're putting it in. Nobody wants any surprises in the recovery room. And it can be done without any special equipment. More on that later. The bad thing is it was really hard to learn once you learn the other way. It's kind of like learning how to shave in the dark with your wrong hand. It's not that easy, but you can do it, and I thought it was worth it. You do need two assistants, and one of them has to be smart. It has to be really smart. So that's a drawback. I don't know. My assistant is great, and I love him, and he's but this thing would grind to a halt if he left until I replaced him. And it can require special equipment if you want it to. There's some guy making a fortune selling operating room tables at $150,000 a crack to let you do this procedure, but you don't need the thing. Falmouth Hospital, when I approached them in the beginning, I think they're still laughing about it, but they said no, we didn't really need that. And so I learned how to do it without it, and then when we started to do lots of them, they asked me if I wanted the darn thing because I guess they felt bad about it. And I don't want it anymore. I like it better without it. So anyway, so that's the hip. In the shoulder, the timeline's about the same. This stuff all sort of happened in the 50s and 60s and 70s. And in each one of these cases, it was a guy that was just a visionary. In the hip, it was a guy named John Charnley. In the shoulder, it was a guy named Neer. In the knee, it was that guy whose name I can't remember, except I think it was Insall. And you guys don't care. I could have made all three of those up. And you don't know if I did. But so the shoulder, the anatomy is different. The anatomy of the shoulder is really different. Even though it's a ball in a socket, the shoulder socket is this tiny little pear-shaped thing. It's just teeny. It looks like an almond. I mean, it's little. It has a little bit of a dish to it because it has some soft tissue that comes off of it. But the ball is huge, the socket is tiny, and it lets your arm do crazy stuff. If you could do this with your hip, we would all be in trouble because we would fall down all the time. But your shoulder has so much freedom, and the cost of that freedom is that it was really hard to figure out how to replace the socket part because there's not very much bone there, and you've got to attach the thing to the bone. So the when a shoulder ran out of gas like this one did, it was easy to replace the ball, which is why they invented the hemiarthroplasty way before the total shoulder. But the socket thing was always a problem. The other thing that's a problem with shoulders is you're not going to be normal usually not going to be normal when it's over. No one's going to say, oh, you had your shoulder replaced, you can go back to work as a guy that chops up logs or does heavy industrial work. You're not going to grab a jackhammer with your fake shoulder and go off to work. But the pain relief can be remarkable, and it can be life-saving. And a lot of times we do it for pain. We don't really do it for function. And the function isn't always bad. It's just not as good as, nothing's as good as a hip, and a knee is better than a shoulder. And all the rest of those joints that I talked about earlier fall way behind. The type of surgery in the shoulder is determined by the degree of damage to the cartilage, the degree of damage to the socket, which is really important, and the whether you have a rotator cuff or not. If you have a rotator cuff, you get one kind of surgery. If you don't have a rotator cuff, you got to have a different kind of surgery. So the rotator cuff is this big hunk of tendon that wraps around the ball of your arm, and it's essential to know what you got. So the ladder of treatment is sort of, like I just said, there's a hemiarthroplasty, which is just a ball on a stick. So you just stick it on there. And then there's a total shoulder, which is a ball on a stick and a socket. Oh man, this is what happens when you make your slides on a Mac. Maybe, is that what happens? I don't know. I don't know why it says that. That's kind of disheartening. And then a reverse is you switch the whole thing around. You put the ball where the socket used to be, you put the socket where the ball used to be, and magically this big hunk of muscle out here called the deltoid functions like a rotator cuff, and your arm works. Invented by a Frenchman, which for all the people that like to make French guy jokes, that you got one against you on that one. But that's what happens inside the shoulder in particular. And then this stuff is general stuff. So what can go wrong? With something as simple as joint replacement, it's hard to figure that anything could ever go wrong. But things go wrong. Anesthesia can be a problem. People can throw up. People can not wake up. People can, things can happen. They don't usually, and we don't like to talk about that stuff, and we don't think about it all the time. But you have to think about that on some level. The anesthetics that are available today are a far cry from the anesthetics that were around when most of the people in this audience were maybe having surgery, when you were younger. All those anesthetics were harsh. They were kind of horrible. They made people sick. All that stuff is better now. But you still have to, essentially, got to go to sleep and then wake up, at least the part we're going to operate on. And then infection. Infection is the bugaboo of all this stuff. We hate it. We stand on our heads to make it go away. It still happens. Doesn't happen very often, but it happens. And it can be devastating. It can cause the whole thing to go to heck, and you have to take the whole thing out and start over again. It's a big problem. So infection is bad. Bleeding happens, but bleeding you can fix. If there's too much bleeding, you can give people blood. And there's lots of tools to help control bleeding. And then, of course, if you can bleed too much, you can also have blood clots. So people get blood clots and pulmonary emboli. Pulmonary embolism is a blood clot that gets stuck in your lung. All this stuff, this is kind of a bummer slide. I don't know why I put this in here. But all this stuff happens, but none of it happens very often. And we spend an inordinate amount of our time worrying about this stuff and preventing it. So it's not like it's a crapshoot. I mean, we're thinking about all this stuff. Pain and swelling. I mean, it's big surgery. It hurts. I'm going to tell you, you're going to go home the day after I replace your hip, and you're going to look at me like I have 3 heads. There's better ways to manage pain these days. It's not, here's a jar of Percocet, have a nice day. We've got injectable stuff. We've got long-acting local anesthetics. We've got all kinds of stuff. And it's better. It's not perfect, but it's way better. Better than ever. Okay. Oh, and nerves and vessel compromise. Joints they live inside you. There's nerves and blood vessels that go, zooming down the highway past them. We hopefully know where they are. We can avoid them. And it's very rare that anything happens in that situation, that those injuries don't routinely happen. Where am I there? Oh, and then allergies. I don't know what it is. People are allergic to stuff. People are allergic to metal. So the most commonly affected metal is nickel. So a knee replacement is made out of this stuff called cobalt chrome molybdenum. So there's no nickel in there. Well, I don't know. Apparently the people that make the things forgot to read the fine print, because there is nickel in there someplace, and you can be allergic to your own joint replacement. It's a terrible thing, but it can happen, and we're recognizing that more and more people are getting on that sooner. People are building joint replacements without nickel in them. They're made out of this stuff called oxinium, which God knows, expensivium. It's just, who knows? They're making all kinds of stuff. So the allergy thing is a real thing. It seems like a bigger thing than it used to be, but it's a thing that people are getting their hands on. So that was kind of a whirlwind overview of joint replacement. I never get to talk about surgery. I'm always trying to talk you guys out of it. So this is it's a different kind of talk for me. But I guess it's kind of honest, because this is what I do for a living, and not that I want to inflict pain on you guys, but I want to be able to fix stuff. And talking about the last year's stuff wasn't as much fun as this. But this was admittedly a quickie, but that's kind of the deal. So if anybody had any, Julie, do you want questions all together? Or questions now? Okay. Does anybody have any questions? Yes, ma'am.
Are you affiliated with both Falmouth? Oh, okay. Are you affiliated with both Falmouth and Cape Cod?
Oh yeah, no, I forgot to say that. When I work here, well, here, not in the Seacrest. I'm the pool boy. I work at Falmouth. Yeah. As of this moment, the two campuses are pretty separate in terms of physician credentialing, but Paul Houle and I are we're hot on the trail of fixing that, and I think in relative short order we'll be able to be active at both campuses. But right now I'm credentialed over here. Yes, ma'am.
How do you feel about needing to take an antibiotic before you have like dental work done or anything invasive?
After a joint replacement?
Yes.
I feel really good about the fact that if you don't do it, it'll make me really sad. So, yeah, you got to do it. There have been recent studies that said you don't. I don't know who's trying to save the world what, but 4 amoxicillin tablets cost about 8 cents, and an infected joint arthroplasty costs about $750,000. So I'm in favor of spending the money on the amoxicillin.
Can you tell me if that has to continue for your lifetime?
Lifetime.
Okay.
Yeah, a lot of people say, oh, it's been around for 10 years. You don't need to do that anymore. And then you can talk to the lady that was in my practice 2 years ago who, at 11 years, decided that she'd had enough amoxicillin and she ended up with an infected hip. Maybe it's anecdotal. Maybe it would, I don't know. But it happened, and like I said, amoxicillin's cheap. And I don't think anybody's going to grow a Superman-eating bacteria because I gave you 4 amoxicillin tablets when you went to the dentist. So yeah, lifetime, very, very important to me and to most of us. Yes. Sorry, I have it on one end
Hi.
of the room.
With regard to hip replacement, why is the dislocation rate vary among the 3 different surgical approaches?
That's a great question. It varies because of what you do to get in there. When you go into the hip from the back, you, by necessity, have to cut open the back of the hip. When you bring your leg up like this, all the stress is on the back of your hip. When you repair the things that you cut to get inside, it's never as good as it was before you cut it. You have a cesarean section, they don't want you to have a live birth after that. It's just repaired stuff is not as good as, the only exception to that is bone, and someday you guys can invite me back for a bone lecture, but bone repairs with bone. Everything else repairs with scar tissue, and it's not as strong as the original stuff. When you do a hip from the front, you weaken the front, and most people can't fold themselves backwards to put strain on the front, the anterior capsule. So with the exception of some extreme yoga moves, most people are not going to stress the front, and so that's why that happens. Okay? Sir?
You said you weren't going to talk about it, but could you give us some tips for avoiding joint replacement?
Oh, man, you should have been here last year. Yeah, you'll get some more. Okay, good.
Do you know what he's going to say?
No, but that's why I'm not going to leave. But if you're not satisfied when this is over, I will not leave till you say it's time for me to leave, and I'll talk to you about that. Ma'am.
2 quick questions. Do you think that supplementing collagen has any positive effect?
Truly, no. I think it's food. And I think when you eat it, it gets chewed up. Now, maybe if you're deficient in the building blocks that it's made out of, but I have a hard time seeing how that stuff's going to swim through your digestive system into your joint without something happening to it. But,
I'm sorry.
Mm-hmm.
And is there do you know anything or can say anything about stem cell replacement for?
Yeah, the whole stem cell thing is a cool concept, which fits into your question about what can you do some other time. But it's a big enough topic that it's a topic for another day, I'm afraid, because it would. I mean, you guys would all fall asleep because I would keep talking. Yes.
You spoke about the ceramic part in the hip
The-
use as opposed to the other part, and you mentioned the cost of it being more expensive.
Okay. The question was ceramic femoral heads, and who cares if they cost more unless I have to pay for it? I'm extrapolating your question. So ceramic femoral heads are made out of this stuff which I always told people was zirconium, but it's really not. It's some other onium that zirconium sounds better, and once again, you guys wouldn't know if I was lying. So let's say they're made out of zirconium. They're pink. They're really kind of cute. And they are incredibly strong. A friend of mine hit one with a golf club, and I'm glad it wasn't his driver, but it broke the driver. It didn't break the head. And they're really smooth. They're orders of magnitude smoother than a polished metal head. And they don't cause trunionosis, so the corrosion of the stem. So they're great, and they do cost more. At this point in the world, the hospital eats the cost. Someday, that's not going to be the case, but right now, it's the cost of doing business, and they're not. I mean, they're $700 instead of $500. I mean, big whoop. For your life, $200 is okay. At this point in time, we do get the operating surgeon gets to pick the implant up to a point. We have a one vendor shop, so all the stuff that we use comes from one company. Now the heads, even though they come from that company, are all made by these guys in Germany. There's only one company that makes them all, and they do a bang-up job with it. Yes.
We have time for 2 more questions.
Uh-oh.
And then we'll encourage people to speak with you
Sure.
afterwards. One's here, one's here. I just wanted to publicly thank you because 4 years ago you did a bilateral anterior hip replacement for me and it was very successful.
Oh. Thank you. Thank you. Yes, sir.
Yes, I'm curious as to how you reattach tendons or muscles to the bone.
Well, it's a great question. If you didn't hear, the question was how do you reattach a tendon? It would be a tendon to a bone because a tendon is the thing that attaches a muscle to a bone. With any luck, you don't have to because you didn't cut any of them off the bone, which is another benefit of doing a hip from the front. But when you attach, like a rotator cuff tear, the rotator cuff gets torn off the bone, you have to screw it back down onto the bone. Typically done with things called suture anchors, which are plastic anchor, not screwy looking things with string that comes out of them. You screw it into the bone and then use the string to bring the soft tissue over and hold it down to the bone. You have to scratch the bone so that it bleeds. You have to scratch the tendon so that it bleeds and have the two bleedy things stuck really hard together so that nature will come along and make it one again. It's never as good as it was. Prevention is way better than cure. But that's the basic science. You just got to hold the two things next to each other rigidly enough that the thing grows roots again into the bone. Okay. Thanks, you guys. I really appreciate it.